endoscopic label repair, TAM osteochondroplasty, and capsular application in patients with hip dysplasia shows early clinical benefits.
Thank you. Today I'm going to talk about endoscopic shallow acetabuloolast combined with arthroscopic label repairs, CAM osteoplasties, and capsular application in the patient with hip dysplasia shows the early clinical benefit. Here is my disclosure. The background. The patient with hip dysplasia do not benefit from arthroscopic management of label alone. We devised a new fully arthroscopic approaches consisting of simultaneously treating the acetabular deformities and label clearance and CAM regions and capsular laxities, which is going to be published in arthroscopic techniques. And here we evaluated the early clinical outcome of these approaches. So patient and method. Between October 2011 and May 2012, 32 patients with hip dysplasia were enrolled in this study. 15 patients was excluded and 1 patient was lost for follow-up. So minimum 1 year follow-up and mean age 37.6 and 4 male and 11 female. So here is case descriptions. The 17-year male long distance runner with left hip pain for the past 6 months. So limited range of motion, flexion at 100 degrees, and he had a positive impingement sign, and pelvic AP view shows a CE and 13 degrees. False profile view shows VC at 18 degrees. So stepwise approach for endoscopic shallow acetabuloolast. We're going to show you the first, at the beginnings, we usually intraarticular procedures consisting of intraarticular evaluation and labrum refixation and femoral osteoplasty. And we do capsule application at least 4 to 6 micron suture, and also we switch the scope to the extra capsular space. So we switch the scope under the fluoroscopy. Video doesn't work. Yeah. And then optimal visualization was obtained by Shaver and we identified that here is a reflected head of the femoris, and we divided it. And we extend the mid-anterior portal, and we place the 2.4 mm guide wire along with the capsule. So after evaluating the location and the angle of the guide pins, we introduce the osteotome to make the slot along with the guide wires. And then we adjust the width of the slot at least makes at least 5 or 6 mm wide. We harvested the bone graft from each lateral side of the iliac crest, and we made the wedge shape, and we drilled holes and placed the skewer to the parallel drill guide introduced. And we introduced the bone graft with guide wires by press-fitting fixations. So here, this slide shows the preoperative, post-operative, and 12 months after surgery X-rays. So overall, patients were excellent, and modified Harris hip score significantly improved from preoperatively and post-operatively. And non-arthritic hip score also improved similarly. So conclusion, this entirely arthroscopic approach can be beneficial to the patient with hip dysplasias. The advantage is less invasive than conventional surgery, while simultaneously addressing both intraarticular pathology and the underlying skeletal abnormality. Thank you for your attention.
Do you have any criteria for when you will do the shelf and when you would consider a PAO, or does all dysplasia get a shelf procedure?
Yeah, actually, it's difficult. A good point. Actually, those patients fall into the gray zone between the PAO and the hip arthroscopy. If the patient have a CE angle more than 20 degrees and VCA angle more than 20 degrees, we do the hip arthroscopy for the management of those patients. But CE angle from more than 0 degrees, less than 20 degrees, we do those procedures.
Thank you. We're out of time.
Yeah. Okay. Hold up.
Soshi.
Yes.
You know, I admire your technical expertise, and but what concerns me is you're doing a less durable operation for hip dysplasia. We know that shelves don't work as long in this condition. Now, that case you showed was a fantastic example of a lovely mild dysplastic case. Now, if you do a PAO on him, you're almost going to cure him. And I'm just sort of concerned that you're doing a very elegant operation arthroscopically, and I admire your technical expertise. But unfortunately, he's going to be back in his 20s or early 30s, and with a worse hip than if he'd had a PAO. So that's my concern with this. I'm just wondering, you know, you have a rich tradition of acetabular reorientation in your country. I'm just wondering, you know, why you're not kind of doing that in these kind of cases.
Yeah, that's a good point. As far as investigation is needed to evaluate the long-term clinical outcomes.
Thank you very much. Thank you very much. So we switch to the next presentation. Straight Jonathan, who is